Good afternoon, everyone. I'm Dr. Monica from Shield Healthcare. I welcome you all on behalf of my company. And today our session is going to taken by Dr. Parag Biniwale on dysmenorrhea. And before starting the session, I would like to give a brief introduction on Shield Connect page. This is our Shield Connect page, which is basically a knowledge information sharing page, which have different blogs and upcoming webinars and various newsletters, awareness programs. And we are even connected with all the doctors who are overall India. So this is about Shield Connect page, and today's topic is regarding dysmenorrhea, and our speaker, Dr. Parag Beniwal. I welcome you, sir. He is the president for Pune OBGYN Society, PG teacher and unit head, Kamala Nehru Hospital, recipient of Dr. C.S. Dhawan Prize. Welcome you, sir, for today's session, and I'm handovering you to sir.
Thank you. All right, I'll just quickly share my screen.
Yes.
Okay, is my screen visible?
Yes, sir, it is visible.
Yes, sir.
All right, thank you. Good afternoon. I bring greetings from the Pune Obstetric and Gynecological Society, and it's indeed a pleasure to connect with everyone on the Shield Connect platform. And we'll be talking today about a very, very common yet bothersome problem, and that is dysmenorrhea. Now, dysmenorrhea is something which almost all women suffer any time of their life. So typically, when we say a woman is suffering from dysmenorrhea, it means that she has painful menses. And this is derived from the Greek name that is dys is painful, meno is monthly, and rhea is flow. So menstruation, which becomes painful, and typically this could be during the menses or sometimes even before the menses start. And generally, the pain subsides at the end of the menstruation. So pain may start before the onset of bleeding. So we used to call it congestive dysmenorrhea, and spasmodic dysmenorrhea is the pain which used to take place during the actual bleeding periods. We know that it is a common condition and it is characterized by severe cramping, which is noted in the lower part of the abdomen. Why it is important? Because in some girls or some women, it leads to their disturbance in day-to-day activities. So girls, because of pain, discomfort, do remain absent from school, and then they do have certain limitations on social activities or even academic activities. This was a study which was published in 2017, talks about the same, and dysmenorrhea and its effect on school absenteeism. So the prevalence of dysmenorrhea and school absenteeism was found to be 73%, and 13.1% school activities were affected because the girls were unable to cope up with the pain during their periods. So this has a negative impact on the class concentration, and it also had impact on participation of girls in social and sports activities. Now, how common is it? It won't be wrong if I mention that all women are sometime or the other affected by dysmenorrhea. The severity may vary, but in general, it is estimated that almost 90% of women of childbearing age group do suffer from dysmenorrhea of varying degrees. So not every time the pain will be so much that the day-to-day activities will be difficult. Now, how do we classify? So typically, we classify dysmenorrhea into primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea is something which is noted in younger women. So women between the age of 17 and 22 are the ones who generally suffer from primary dysmenorrhea, while the second dysmenorrhea is found to be more common in older women of childbearing age group. Coming to primary dysmenorrhea. Now, it is defined technically as painful menses in absence of any pelvic pathology. So typically, it is seen in nulliparous young girls. So a girl who's just started her menses is brought to you to us in the clinic. She's say 15 or 16 years old, and then she experiences a lot of pain. So whenever we investigate these girls, and if there is nothing found on her examination or an ultrasound, then we say that she's suffering from primary dysmenorrhea. And these girls will tell you that the pain and the bleeding is seen together. So the onset of pain is along with the onset of bleeding. Pain is typically cramps, colicky, and it is associated in midline, which can last for 12 to 72 hours. And as early as 6 to 12 months is the time after menarche when girls start experiencing dysmenorrhea. So it is common in nulliparous girls, and it is postulated that it may improve after childbirth. And when we inquire into history of these girls, we realize that there could be a positive family history of dysmenorrhea. What are the common symptoms? So pain is something which can be noted in various forms. So the commonest probably is the lower abdominal cramps, lower back pains. In extreme cases, girls may experience vomiting, weakness. Because of excruciating pain, they may even faint at times, and some of them suffer from headaches. Coming to the pathophysiology of primary dysmenorrhea. The pain of primary dysmenorrhea is caused by excessive E2 and F2 alpha prostaglandin production, which is which happens or which takes place in secretory endometrial cells. Mind well, and when we say secretory endometrial cells, it also means that it is post or in the luteal phase or post ovulatory phase. It means that there could be some association with the hormone progesterone. Now, this prostaglandin release in turn causes uterine contractions, uterine muscle ischemia, and thus leads to increased peripheral nerve sensitivity. Elevated prostaglandin levels are noted in girls who have excessive pain during menses, because we know that the uterine activity is much more during menstruation as compared to asymptomatic women. So menstrual bleeding is generally triggered by progesterone withdrawal following demise of the corpus luteum. So all in all, progesterone is one of the most important contributing factors to have painful menses for girls who suffer from it. So when we look at this particular chart, so it is the progesterone which has an impact on increasing the prostaglandins or endoperoxides and metabolites. This leads to increase in the myometrial contractility. Many a times there may be arrhythmia or dysrhythmia as far as the contractility is concerned. There is reduced blood flow, which is responsible for ischemia, and then it leads to pain because of increased uterine activity, uterine ischemia, and even sensitization of nerve terminals to prostaglandins and endoperoxides. What are the risk factors? Girls who have early menarche do show dysmenorrhea more commonly. Low body mass index, so probably girls who have higher body mass index they suffer much less as compared to girls who are thin. Prolonged menstrual flow for 7 days or longer, girls are more likely to experience pain. Pelvic infection is an important risk factor. So girls who have endometritis or pelvic inflammation are likely to suffer more because of dysmenorrhea. There could be some genetic or family history which may be associated with it. Premenstrual somatic complaints are also associated with painful menses, and girls who are victims of sexual assault are more likely to experience painful menses. Coming to the management, and when we talk about medical management, we divide it into two. Traditionally, we talk about, or the first line therapy is non-hormonal management, and which include the NSAIDs. Mefenamic acid is by far the most commonly used drug for treatment of primary dysmenorrhea. Many a times we add uh, to mefenamic acid some antispasmodic, which definitely adds little value and relieves pain in a better fashion. Naproxen sodium can also be administered to these girls every 6 hours, which will give her good relief. And diclofenac sodium in the dose of 75 to 100 milligrams per day may also offer good relief. The hormonal management include combined oral contraceptive pills, and in a short while we will see how it helps in women overcoming the problem of dysmenorrhea. And a progesterone containing intrauterine system also helps in reducing the painful menses in women who are suffering from dysmenorrhea. Of course, there are over-the-counter prostaglandin inhibitors like ibuprofen or aspirin, which are being used, wherein commoner drugs that are used include ibuprofen in higher doses, mefenamic acid, which can be started in the dose of 500 milligrams 6 to 8 hourly, and then one can reduce the dose to 125, rather 250 milligrams every 6 to 8 hours. Maximum permissible dose is about 1250 milligrams. Naproxen and can also be tried in these girls to get rid of the pain which is bothering these women. The NSAIDs also come with their share of side effects. So typically, these women suffer from gastric irritation, nausea. Some of them do develop GI ulcerations, nephrotoxicity. Mefenamic acid may by itself cause blurring of vision, headache, etc. Bronchospasm is a known entity, especially in asthmatic patients, so one has to be very careful. And hypersensitivity reaction, though not very common, should be kept in mind when we are prescribing NSAIDs to these women. Coming to the combined oral contraceptive pills. Now, COCs should be considered uh, for treatment of dysmenorrhea in women, especially if they are uh, contemplating contraception in addition to pain control. The combined COCs yield the best results, with progestin only contraceptive being less effective. Depo-Provera can also be used, but COCs would definitely be better in women who are suffering from dysmenorrhea. And how does it act? We know that the combined oral contraceptive pills will be responsible for inhibition of ovulation. So there would be reduction in the prostaglandin production. The endometrial thickness also reduces, which in turn is responsible for less pain as well as less amount of bleeding. Before we go on to the nutraceuticals, just one word about the LNG intrauterine system and how it works. Now, LNG intrauterine system has a progesterone, that is levonorgestrel, which is released in the uterine cavity in a very small dose of 20 micrograms per day. Now, this particular drug, which is released inside the uterine cavity, it exhibits two actions. Number one is thinning of endometrium. We know that every day, if we keep on supplementing progesterone, the progesterone or the endometrium will become atrophic. And the second action is on the uterine vessels, where the uterine blood flow tends to reduce. And these two actions are responsible for reduction in the pain as well as in the bleeding in women who are suffering from dysmenorrhea. Now, coming to the nutraceutical components, which are found to be helpful in treatment of dysmenorrhea. Number one is bromelain, and where does this bromelain come from? It comes from pineapple juice and pineapple structures. How does it act? We know that prostaglandin uh, E1 and PGI2 are supposed to be anti-inflammatory, while PGE2, PGF2 alpha, and thromboxane A2 are pro-inflammatory prostaglandins. Now, bromelain will have its antispasmodic effect by inhibiting arachidonic acid, so which is a precursor of prostaglandins. It will also reduce thromboxane A2, PGF2 alpha, and PGE2. It also exhibits analgesic effect. There would be reduction in the pain because of decreased forceful contractions, and there would be anti-inflammatory effect of bromelain, which is modulated through TNF alpha and interleukins. This is a study which was conducted in young girls, which was published in the Indonesian Journal of Medicine. And here, girls between the age group of 15 to 17 were enrolled. Girls received pineapple juice, that is, which contains bromelain, and it was compared with a placebo. The treatment was given for 3 days for 3 consecutive cycles, and it was found out that the pain score before treatment and after treatment with pineapple juice was quite significant. And that made researchers think that this may be a molecule which can relieve the pain and the agony associated with dysmenorrhea in younger women. The second component is the rosemary extract or ursolic acid. We know that this is the active constituent which is responsible for its inhibitory action on the COX2. We know that COX2 enzyme inhibitors of COX2 enzyme can reduce the production of prostaglandins, and mefenamic acid has similar mechanism of action to reduce pain. So by reducing prostaglandins, it can show antispasmodic action and analgesic action, and rosemary extract can reduce the production of interleukin beta and TNF alpha, that is tumor necrosis factor alpha, which has anti-inflammatory effect. Now, this was a study which was published again in 2019 in Iranian women, and 82 women from the age group of 18 to 25 were enrolled. They were divided in 2 groups, ursolic acid versus mefenamic acid. Participants received 250 milligrams of ursolic acid capsule or 250 milligrams of mefenamic acid capsules for first 3 days of menses. A visual analog scale was used for pain, and that is from 0 to 100. And the findings which were noted was with ursolic acid, the pain score, which was before treatment, was around 40, reduced to 23, which was quite significant. As also, it was found out that the mefenamic acid reduction in pain was also significant. So it was concluded that ursolic acid is as effective as mefenamic acid in reducing pain in girls who are suffering from dysmenorrhea. Now, curcumin is the next constituent. Now, turmeric is derived from Curcuma longa, and it includes curcuminoids such as curcumin, dimethoxycurcumin, and bis-dimethoxycurcumin. It is a member of some religious diet in numerous Indian and Asian cultures. So how does curcumin works? Curcumin works by modulating the inflammatory response by regulating the activity of COX2 lipoxygenase and nitrite oxygenase, which can so that it will reduce or even inhibit uterine contractions. The mechanism of blocking uterine contractions through curcumin is by reducing the influx of calcium ions into the calcium canal in the uterine epithelial cells. The anti-inflammatory action is noted where curcumin is frequently used with bromelain to improve its absorption. What is the effect of curcumin on primary dysmenorrhea? This was a study which was published in 2020. Here, 32 young women with primary dysmenorrhea were enrolled. Women were divided into two groups: a curcumin homemade drink and the drink by researchers. Women had the drinks from the first day of menses until the third day of menses in the dose of twice a day, that is 100 ml. And it was noted that uh, the homemade and the researcher drink both showed significant reduction in the pain by in the pain caused by painful uterine contractions in girls with primary dysmenorrhea. Uh, Pentone and anethol, again, where these come from. Now, the phenyl extract basically acts more or less like diclofenac. The pentone is the main component of phenyl that inhibits PGE2 and thus reduces uterine contractions. So it is a good antispasmodic. Anethol is the main component of phenyl. It is structurally similar to dopamine, which binds with the dopamine receptors and thus exhibits the analgesic effect. And the anti-inflammatory effects of phenyl is due to inhibition of histamines H1H2 receptors, which are again responsible for cough and cold. This is how the penchone or the phenyl extract acts, and you can see that how it has a negative impact on the synthesis of prostaglandins. So if these measures fail or the medical measures fail, rarely one may need surgical procedures like cervical dilatation. Presacral neurectomy is another thing described in the literature. In last 30 years of my practice, I have not had any opportunity to do a presacral neurectomy because the girl was suffering from severe dysmenorrhea. Yes, cervical dilatation, we did do it long ago in younger women who did not respond much to uh, analgesics. What are the general measures which can be implemented to improve dysmenorrhea? We must encourage women to continue their normal activities. So the traditional saying of when the girl is in her menses, she should be uh, she should be sitting in one corner avoiding all activities. The answer is big no. She should continue her routine activities. If she's exercising regularly, she can continue doing that if she's comfortable. Avoid stress, avoid lack of sleep. Gentle abdominal massage can be of help in some women. Coming to the second part, that is secondary dysmenorrhea. Now we know that secondary dysmenorrhea is something which takes place because of some pelvic organ diseases. So what are the causes of secondary dysmenorrhea? So it could be because of gynecological conditions, typical being endometriosis, congenital uterine anomalies. Yes, they are responsible for painful menses because of the dysarrhythmias seen in the uterine muscles. Women who suffer from STIs and PID are more prone for development of secondary dysmenorrhea. Women with adenomyosis, uterine leiomyoma, and in rare situations of cervical stenosis, there could be chances of secondary dysmenorrhea. However, there are other conditions which may mimic or lead to painful menses, which includes high tone pelvic floor dysfunction, irritable bowel syndrome, bladder pain syndrome, pelvic adhesions, or even inflammatory bowel disease. How do we diagnose? Now, diagnosis has to be based on the history and clinical examination. So, if the onset of, we have to inquire about the onset of symptoms. If it is several years after menarche, we must find out if she has fever or white discharge. Is there any intrauterine device that is inserted? We must also ask about history of recent pelvic surgery because then it could be adhesions. Heavy menstrual bleeding is usually because of conditions like adenomyosis or endometrial polyp or even fibroid. And if the woman is suffering from infertility and dyspareunia, probably we are dealing with a woman who's suffering from endometriosis. So examination will definitely help in confirming our findings, and we need to investigate these women. It is important that we do their CBC to treat anemia related to heavy menstrual bleeding or due to pelvic inflammation. We can take the cervical and vaginal swabs for culture. A transvaginal ultrasound is important. It will tell us about the uterus, about the ovaries. So conditions like pelvic masses, uterine fibroids, or polyp pelvic abscess, though it is very rare, and even adenomyosis can be noted on a good transvaginal ultrasound. Laparoscopy will be useful in women who have endometriosis. We always used to say that uh, the gold standard in diagnosing endometriosis is laparoscopy, but it is no more true. A good ultrasound with a 3D or possibly a Doppler would be a better diagnostic tool, but laparoscopy can certainly be used for diagnosing and treating conditions like endometriosis in women. Hysteroscopy is definitely useful to deal with intrauterine pathologies. So, women who have endometrial polypi will be benefited by doing a therapeutic hysteroscopy where we can remove the polyp. We can also take endometrial tissue for histology and offer them correct treatment. So this is the algorithm which talks about management of dysmenorrhea. So we must take medical history, ask for history of any previous history of diagnosis of pelvic pathology, relation with menstruation, uh, plus pain, what was its onset, whether it for how long does it last, whether it radiates to back and thighs, or it is associated with accompanied by other symptoms like diarrhea and vomiting. So if nothing of this sort is found, then possibly we are dealing with a case of primary dysmenorrhea, and the secondary dysmenorrhea will certainly have a pelvic pathology. So how do we compare primary and secondary dysmenorrhea? So primary dysmenorrhea will be noted in younger women. The onset usually is 6 to 12 months after menarche, typically within the first 3 years. Secondary dysmenorrhea can be any time once the disease uh, takes its toll. Uh, Primary dysmenorrhea is seen in ovulatory cycles because we've seen that progesterone is the one which is responsible for all the painful situations. Symptoms would be more or less the same, but women who have secondary dysmenorrhea will have heavy menstrual bleeding or dyspareunia associated with it. Uh, Usually, the pain will start in the lower pelvic or abdominal region associated with onset of menstrual flow, and it can last for about 8 to 72 hours. While women who have secondary dysmenorrhea, they may complain of change in time of pain onset during menstrual cycle. The intensity of pain may vary. The pain may be associated with an underlying pelvic pathology such as endometriosis, pelvic inflammatory disease, ovarian cyst, or even fibroids. And vaginal examination will also be of great help, where you may be able to diagnose some pelvic pathology on a proper per vaginal examination. So dysmenorrhea is something which should not be confused with premenstrual syndrome, because this is a syndrome where quite a few women do suffer just before the menses. The premenstrual syndrome symptoms will shortly resolve after the menstrual flow has begun, while dysmenorrhea can continue up to 72 hours. Just a quick word about the PMS. So it is a group of physical, emotional, and behavioral symptoms which typically are seen in the luteal phase of the menstrual cycle. So again, possibly progesterone is the culprit, and it does often interfere with work and day-to-day activities. And the symptoms relieve as soon as the menses begin. Women will typically feel bloated. They may experience weight gain or edema. They have tender breasts. They may experience hot flashes, headache, nausea, change in bowel habits, and very importantly, they may be emotionally disturbed. They are irritable, aggressive, depressed at the same time. What is the cause? There are so many theories, but no cause to pinpoint. Possibly progesterone might be the culprit. Vitamin B6 deficiency is one of the postulations, because whenever we are talking about therapy, we do supplement women with vitamin B6 and they are relieved of their symptoms. And there could be a psychological origin to this. But it is important that we remember that ovulation and progesterone production are important factors in this syndrome, and drugs that inhibit ovulation relieves the premenstrual syndrome. So typically, it is the combined oral contraceptive pills which may help these women to get rid of a premenstrual syndrome. Coming to the management of PMS, counseling is important. We must reassure women, explain them that this is a treatable condition, though the symptoms are real, but they would be relieved with some kind of therapies. Lifestyle modification is important. 20 to 30 minutes of exercise every day will be helpful in these women. Symptomatic treatment, diuretics may be offered to bloating. Most of us are not using it. Antiprostaglandins for cramp and pain and breast tenderness, one can think of giving bromocriptine, but vitamin B6 is something which is more preferred. We can think of ovulation suppression by COCs. Once upon a time, we did use danazol, not used anymore. Medroxyprogesterone acetate can be offered continuously, and evening primrose oil can also be of help in women who suffer from premenstrual syndrome. So this is the pathway for dysmenorrhea, and this is something which all of us must remember, because whenever we are treating dysmenorrhea, the first line of therapy is essentially medical. And when we say medical, we always begin with a non-pharmacological treatment. If it relieves symptoms, uh, then we must ask the girl to continue the same kind of treatment. And if uh, it does not relieve the symptoms, we should think of giving her NSAIDs. And if NSAIDs are not effective, then one has to resort to hormonal pills, which will be definitely useful. So to conclude, dysmenorrhea is a condition which is quite common in women. As I mentioned earlier, almost 90% plus women suffer from dysmenorrhea. There could be a family history associated with it. So women, we must inquire into a family history, bleeding duration, presence of clots, because that could be an additional factor for dysmenorrhea. Appropriate intervention through a change in lifestyle is extremely important, and it has to be advocated as the first measure whenever we are treating women with dysmenorrhea. The barriers to seek medical attention by dysmenoric females need explorations. It is important that health education on puberty and menstruation is regarded as inadequate for many young women. So we as healthcare providers for women should take a note of this and educate our women in a better fashion, because we know that if we educate the girls, if we tell them what exactly is going on with their body and treat her symptoms, that will be something which is important from the woman's perspective, because it will have a positive impact on the quality of life for that particular woman. Thank you very much.
Thank you so much for the session, sir, for the knowledge information which you have given in detailed description regarding dysmenorrhea. I think majority of people would be knowing different new things here. So we have two questions here, sir, in the query box. Shall I repeat those, sir?
Yes, please. Yes.
One question is, how often you see dysmenorrhea patients and what would be the factors which are affecting to treat them?
Okay. Now, first of all, as I mentioned earlier, dysmenorrhea is something which is very, very common, though the studies say that almost 90% women suffer from it. I think all women, sometime or the other during their lifetime, do suffer from painful menses. So, this is something which has to be noted. Now, when we talk about treatment, counseling is a must because we need to reassure, especially the younger women who are just beyond their menarche, that this is something which is going to be with them for some time. It is a temporary phenomenon in most of the cases. It should not affect, or girls should not let it affect their day-to-day routine. And if needed, whatever therapy that is required can be adopted, and women should get rid of these particular symptoms, because we know that if women suffer, it is going to have a negative impact on the quality of life. So this is something which is definitely worth treating. So whenever these girls come to us, we always tell them that even if they have to pop up a pill every month, it is okay. Younger women who do not have any comorbidities can definitely, uh, you know, take a couple of NSAIDs if needed during their menses every month. And even in the long run, we do not expect any kind of ill effects in these women.
Sir, the another question is, what are the non-pharmacological methods which you suggest other than the pharmacological methods, sir?
I think there was a slide which talked about it. So continuing exercise is something, light massage, maybe a gentle back massage also helps in a lot of women. So these are the two remedies, and of course, women should continue doing exercises. If they are doing a particular exercise, there's no reason for her to stop doing that exercise just because she's menstruating. Of course, if she has a lot of pain, if she's not comfortable, she may reduce the, or she may not choose to do exercise for a day or two, but then otherwise she can continue doing it.
Yes. Sir, there were only two questions. Thank you for the explanation, sir. I guess they got their answers very clearly. And thank you so much for your time. And
thank you.
Thank you so much, sir. So,
thank you. It was a pleasure.
Yes, sir. And I hope you do a lot of webinars with us in future too.
Sure.
Thank you so much, sir.
Thank you. Thank you very much. Bye-bye.